There are two types of stroke that this chapter goes into detail about. The first type is ischemic and the second type is hemorrhagic. I really like this picture to help understand the difference between the two. So an ischemic stroke is caused by some type of obstruction that blocks blood flow to a certain area of the brain, leading to lack of perfusion in that area. A hemorrhagic stroke is where the blood vessel ruptures and bleeding starts to build up in the brain, which therefore increases pressure and then also cuts off blood supply to that area of the brain. Another term for an ischemic stroke is a brain attack. So if you remember back to cardiac, a heart attack necessitates immediate care. Same thing with an ischemic stroke. So the term brain attack is used just to stress that sense of urgency when somebody comes in with an ischemic stroke. So one of the best ways to treat and decrease symptoms and improve their functioning after the stroke is through thrombolytic therapy. Now, the key with thrombolytic therapy is that they have a certain window that they have to administer that medication within. So it's key for patients to know exactly when the symptoms started in order to determine if the patient is a candidate for thrombolytic therapy. So the goal is to start it within 3 hours after the onset of a stroke, but in some situations, evidence-based practice has shown that up to 4.5 hours later is also sufficient to improving symptoms and decreasing that loss of function that they experience from the stroke. Some of the different types of strokes include things like large artery thrombotic strokes. So this is from things like atherosclerosis, small penetrating artery thrombotic strokes. So these are also known as lacunar strokes because these leave little holes or cavities in the area of the brain tissue that is affected. So that's why they're called lacunar strokes. So those are of those smaller arteries. Another big type is your cardiogenic embolic stroke. So this is most frequently related to patients who have atrial fibrillation. And if you can remember from MedSurg 1, when you have atrial fibrillation, one of the biggest risks is the development of clots and that clot breaking off and going to the brain and causing an ischemic stroke. Cryptogenic strokes are called cryptogenic because they really don't know what causes them. So they have no specific cause. And then there's other types of strokes that can occur because of patients who are using drugs like cocaine, patients with different coagulopathies or migraines, or even where they have dissection of that vertebral or carotid artery. So when we have an ischemic stroke, this is where a certain area of the brain stops receiving blood flow. So there's a disruption in that cerebral blood flow because a blood vessel is obstructed for some reason. This leads to the patient going into an anaerobic metabolism. So our body normally works through aerobic metabolism. This means this is with oxygen. And this is a better way of creating energy for the body in order for cells to function the way they're supposed to. So when I have a lack of oxygen, my body switches to anaerobic metabolism, which is trying to create energy without oxygen. So the body has to work a lot harder to get even less energy in order for cells to function. So basically what's happening is you have this lack of blood flow that's leading to this anaerobic metabolism. When you have anaerobic metabolism, that sodium-potassium pump isn't able to work properly because my body's not able to produce ATP like it's supposed to. So I have where these ions become imbalanced. And another thing that happens is a byproduct of anaerobic metabolism is lactic acid. So lactic acid builds up and the patient starts to become very acidotic. Another thing that we see is there's a certain area of the brain where you actually have the infarction. So I'm going to show you a picture in a minute with the infarction in the center. So the infarction is complete lack of oxygen. This is where my cells will die and I will not get them back. And then you have the area around the infarction, which is known as the penumbra region. So that penumbra region is the area where it's lacking oxygen, but if I open that vessel back up and reestablish blood flow, I can save that tissue. So my goal is to save that penumbra region by hopefully being able to use thrombolytic therapy. Now, if I don't, basically what happens is calcium is off, sodium, potassium are off, and so is the release of glutamate. And as more calcium and more glutamate is released, there's more vasoconstriction, which vasoconstriction is going to decrease blood flow even further to that area of the brain. So cells are going to start to lose that oxygen and they're going to die, and we're not going to get those cells back once they die. So this is a picture like what I just explained in the previous slide. So when you look at that picture, the very center where it says ischemic core, this can also be known as the area of infarction. So this is the area where the brain tissue is either already dead or definitely going to die. And then you see the area around that and that kind of lighter, darker blue, and it says the penumbra. The penumbra is the area that's lacking oxygen, but if I open that vessel back up and reestablish blood flow, I can get that function of that area of the brain back. So as you see on your left side, that's where you're actually having your stroke. And then once we reopen that blood vessel through thrombolytic therapy or something else, you can see on the right side that you've only lost that ischemic core and we've regained the function of that penumbra region. Signs and symptoms of an ischemic stroke really depend on the location of that ischemia within the brain. So based on the lobe or the area of the brain that ischemia has occurred will determine what type of symptoms the patient will actually have. But some of the common symptoms, like you see in that picture on your slide, that acronym FAST is something important that we teach people, even those who are non-healthcare professionals, to look for, and that they're potential warning signs of a stroke. So big ones are that facial drooping on one side, weakness of the arm, and changes in speech. So if they have a combination of those or anything like that, it's definitely important for them to get that patient to the hospital as quickly as possible. So a lot of patients who have strokes or an ischemic stroke end up with motor losses. This can be a hemiplegia, which is paralysis of one part of the body or one side of the body. And it's usually occurring on the opposite side of the side that is affected in the brain because of the way those fibers cross. Hemiparesis can also happen, which is just weakness of one side of the body. And then you also have where initially they will completely have flaccid paralysis. Those deep tendon reflexes will be greatly decreased or completely absent. And then once those start to return, they usually have a lot of spasticity issues. In regards to communication, a lot of your patients have aphasia. So depending on the area of the brain that's affected, that could be an expressive aphasia or a receptive aphasia. Many of them also have that dysarthria, which is one of those key things we look for in that FAST acronym. So that's the difficulty speaking, or dysphagia, which is the impaired speech. And then a lot of patients also end up having issues with apraxia, which is where they're not able to perform an action that they had known how to do before. For example, you may ask them to brush their hair, and if they have apraxia, they may have forgotten how to do that and would have to relearn that action. The picture that you see on your slide to the left is something called homonymous hemianopsia. This is actually where a patient has blindness in half of their visual field, and this can occur in either one or both eyes. So basically, the patient sees exactly what you would see in that picture. So they're able to see the right side of their field of vision, but they're not able to see the left side. So a big thing we would have to teach patients who have this is to make sure that they're scanning. So for example, if we put a plate in front of them with their dinner, they would only be able to see half of that dinner. So we either just put food on that half of the plate, or we teach them to scan their eyes on both sides so they're able to see everything. A lot of them also have issues with visual spatial relations. So this is where they're not able to determine how two or more objects are within certain spatial areas. So that's one other thing that you may see with a stroke. Sensory losses also start to occur. So this is things where they just either have impairment of touch, or it could be more severe where they don't even know which way their hand is pointing. Another thing you would see is something called agnosia, which is the inability to recognize objects. So whether that's seeing it, hearing it, or touching it, agnosia is not being able to recognize those objects. In addition to many of these other symptoms, patients a lot of times also end up with cognitive impairments or other psychological effects. So these can include things like problems with learning and remembering things, problems being able to pay attention or understand what people are saying. And another thing you commonly see is changes in those emotions, and especially seeing patients who have had a stroke end up with depression later because of the potential losses that they have from the stroke. I love the way this picture differentiates between what you would see with a right-sided versus a left-sided CVA. So when you have a right-sided CVA, meaning that ischemia has occurred on the right side of the brain, then it affects the left side of the body. So the left side will be paralyzed, so they'll be hemiplegic on that left side. Another thing that's really big with a right-sided stroke is that they have a little bit more time or a little bit more of a problem with making good decisions. So they have impaired judgment, they're much more impulsive, aren't able to concentrate for an extended period of time. With a left-sided CVA, this would be a stroke on the left side of the brain that would result in right-sided paralysis or right-sided weakness. The big thing with a left-sided CVA is more of those speech and language issues, and also things are just a little bit slower, so it takes them a little bit longer to understand or comprehend things. And another thing is you see a lot more of that depression and anxiety associated with a left-sided stroke. I like to use an example of a patient getting into a wheelchair to help describe the two right-sided versus left-sided CVA. So if you have somebody who has had a right-sided CVA and they're preparing to get into a wheelchair, they wouldn't even make sure that the wheelchair was locked. They'd just plop right down and have a seat, and not even consider if they were going to make it in the chair or that the chair wasn't going to roll out from underneath them. So big thing with a right-sided CVA is definitely that safety issue because of them not having as good of judgment. With a left-sided CVA, if you have them getting ready to plop into a wheelchair, it would take them a little bit more time. They would think things through a little bit more clearly, make sure that that wheelchair was locked before they had a seat. So a big thing with a left-sided CVA is basically just giving that patient a little bit more time to say things, a little bit more time to do things because they do have a slower performance. When a patient comes in with a possible stroke, a stroke alert is immediately called. That stroke alert sends critical care nurses and those who are trained in stroke care to come and complete the NIH stroke scale. And the priority diagnostic test that we do is a non-contrast CT scan. The goal is to hopefully get that done within the first 25 minutes of them arriving to the hospital. The purpose of this CT is to find out if the patient has had a hemorrhagic stroke. A big thing with a CT is a lot of times that initial CT can come back normal, and this is basically telling us that the patient does not have a hemorrhagic stroke, and if the symptoms have continued and their stroke scale score is very high, that they are currently experiencing an ischemic stroke. So the main purpose of doing a CT is to make sure that the patient's not having a hemorrhagic stroke so that we don't even consider thrombolytic therapy in that case. The next priority that we're doing is we're getting that history from the patient or the family to determine when was the last time this patient was seen completely normal. This will also help us to determine if the patient is a potential candidate for thrombolytic therapy. From there, we will also do some other diagnostic studies, making sure that we're doing an EKG, a carotid ultrasound, MRIs, echocardiograms, and our goal is basically to figure out where did that clot come from and what do we have to do to prevent them from having another stroke because of that cause. Prevention of stroke is really important nursing education that we provide to patients. So a big thing with prevention is our main goal is focused on supporting a healthy lifestyle. So things like refraining from smoking, making sure they're being physically active and maintaining a normal weight, as well as a healthy diet. And people who do have a higher risk for stroke for whatever reason, our goal is to start them on low-dose aspirin to prevent that from happening later. So those are more of our modifiable risk factors. Now, in some situations, we have those non-modifiable risk factors. So when you see patients who are over the age of 55, they become higher risk for strokes. So the higher the age, the more likely, the higher the risk of having a stroke. Another thing is based on age, as patients get older, men have a higher rate of stroke as they age. Whereas if you look at it as an overall thing, you see more women have strokes than men. When we think of race or ethnicities that are at high risk, our big ones that are at high risk are African American, and then from there, Hispanics and Latinos also have a higher risk than Caucasians. Now, another thing we look at is medical history, past medical history. So things like hypertension, sickle cell disease, cardiomyopathy, somebody with atrial fibrillation, all of these conditions put them at a higher risk for stroke. So a big thing we do is make sure that we are treating them appropriately with medications or even surgical procedures to make sure that we decrease that risk for stroke. For patients who have had a TIA or a stroke, there are certain things that they must be on to prevent another stroke in the future. This includes things like anticoagulants such as Coumadin. Most of these patients will also be on aspirin or Plavix or both, as well as a statin to help reduce cholesterol. In addition, patients who are hypertensive will also be on antihypertensives to help decrease that risk for a hemorrhagic stroke in the future. Now, one of the mainstays of treatment for a patient with an ischemic stroke, if they meet the qualifications, is thrombolytic therapy or TPA. So the purpose of a thrombolytic is to break up the clot. And in the next slide, you'll actually see a picture of how TPA works, but the whole ultimate goal is for it to completely break up that clot. When we use thrombolytic therapy, it can be given either intravenously or it can even be given through an artery. The benefit of giving it through an artery is that it can actually be given up to 6 hours from the onset of time of the stroke. The big thing with thrombolytic therapy and the reason that we have a time limit when it's given IV, that 3 to 4.5 hours, depending on the patient, is that after 3 hours, you actually start to see where that necrotic tissue starts to be revascularized, meaning it's going to start getting more blood supply to that area because of collateral circulation. So if we break up that clot and it's already starting to supply more oxygen to a certain area of the brain that had that stroke, it increases the risk for a patient to develop cerebral edema or even for that stroke to turn into a hemorrhagic stroke. When TPA is given, TPA binds to the fibrin of the clot, and then TPA causes plasminogen to convert into plasmin. That plasmin is what actually helps to dissolve the fibrin, resulting in a decreased size of the clot and hopefully ultimately complete loss of the clot. Recent research has shown that endovascular therapy is also beneficial for patients who have had an ischemic stroke if they meet the requirements. So endovascular therapy includes going in through the vessels and using a stent retriever to get rid of the clot and potentially to also put a stent in to prevent further clots from causing a stroke. So the criteria that have to be met for endovascular therapy is that the patient has to have no deficits before the stroke. Another thing is that TPA has to have been given within 4.5 hours of the onset of the stroke. The internal carotid or proximal middle cerebral arteries are the ones that have to have been occluded by the stroke. The patient has to be greater than or equal to 18 years of age. The stroke scale score has to be greater than or equal to 6. And then the aspect score has to be greater than or equal to 6. The aspect score is done by a radiologist, and it's a close assessment of the CT. They look at where the stroke is, the size, and all of that information, and then they create this aspect score. So that number has to be greater than or equal to 6. And then the last thing is that endovascular therapy, them actually going in through the groin, has to be initiated within 6 hours of the onset of symptoms. Prompt diagnosis of a stroke is crucial to improving outcomes for patients. So once the hospital gets a call that a patient is on their way with a possible stroke, or once the patient comes in, that stroke team is called. While the patient is quickly being assessed and sent to CT scan, nurses are very carefully assessing to see if the patient meets the criteria for TPA if it is an ischemic stroke. So chart 67-3 in your book talks about all of the different eligibility criteria for a patient to be a candidate for TPA. So they have to be 18 years or older. They have to have an ischemic stroke. They have to know that the time of the onset of stroke is at least less than 3 hours before. Systolic blood pressure has to be less than or equal to 185/110. Another thing is the patient has to very clearly be having a stroke and that it's not resolving. And then you can keep going through the rest of those criteria. There's a whole list there. Another thing that we look at is potential contraindications for it. So contraindications can include things like it being greater than 3 hours since the time of onset, an increased INR, them having a previous stroke or head injury or trauma within the last 3 months. So if they don't meet any of these criteria, they're immediately considered for a different method of treatment for that stroke. While the stroke team is assessing the patient, one of the things that they're doing is the NIH stroke scale. So that's the National Institute of Health stroke scale. The scores range from 0 to 42, with 42 being the absolute worst. So the higher the number, the worse the stroke is. As you can see on the slide, you can actually click on that link and it will take you to the website where it's actually a computerized scale that can be done based on the patient's assessment. And then I will also provide a handout to you guys as well. Now, when we look at the dosage and administration of TPA, you usually, when someone's going to be a candidate for TPA, or once we have agreed that that is how they're going to be treated, there are always going to be 2 or more IV sites. And then dosage for TPA is 0.9 milligrams per kilogram with a max dose of 90 milligrams. So no matter what, if they go over that 90 milligrams based on their weight, 90 milligrams is the most that we will give. Once they've determined how much to give, they'll give 10% of that via IV bolus over 1 minute, and then the rest of it will be given IV over 1 hour. A big thing that we're doing while the patient is receiving TPA is very closely assessing their neurologic status, as well as watching their blood pressure and vital signs very closely. So you're usually going to be assessing the vital signs every 15 minutes for the first couple hours, and then every 30 minutes for the next 6 hours, and then every hour for 24 hours after treatment. And the whole goal is for the blood pressure to be maintained at less than 180/105, so that way we don't increase that risk for hemorrhage. So big thing we're assessing for while this patient is receiving TPA is making sure they're not having any obvious signs of bleeding or even bleeding into the brain. So for the next 24 hours after they receive TPA, they cannot receive any anticoagulants. And another thing that we do is we make sure that we delay any type of procedures. If we can delay IV insertions, blood draws, NG tubes, catheters, any other type of PICC lines or other arterial pressure devices, we want to try to delay the insertion of those for at least 24 hours so that we don't increase their risk for excessive bleeding and potentially hypovolemic shock. For those who are not candidates for TPA, Other treatments can include things like IV heparin or low molecular weight heparin to help decrease the risk for further clotting. Another thing that we're doing is very closely watching the patient's intracranial pressure. So it is common for patients to develop an increased ICP after an ischemic stroke, especially if it's very large. So like we discussed in chapter 66, management of increased intracranial pressure can be done through things like osmotic diuretics, elevating the head of the bed, maximizing oxygen, and then in addition, they may need to be intubated and hemodynamically monitored until we can stabilize the patient. Some of the potential complications is obviously ischemia. So with an ischemic stroke, I'm going to expect them to have a lack of oxygen to the area of the brain that's affected. So my priorities with a patient who's having a stroke goes back to my ABCs. So I want to make sure that they have an airway and that they're breathing appropriately to maintain oxygen to their tissues. Other complications associated with a stroke include things like UTIs, dysrhythmias, and then especially if they have a lot of weaknesses from it and have become immobile, they're going to have those complications associated with being immobile, like blood clots and pneumonia and skin breakdown. Another thing we look at is their blood glucose levels. So because of that stressful situation and that lack of oxygen, that sympathetic nervous system is going to be stimulated and the blood sugar is going to go up. So our goal in a patient who has had a stroke is to very closely watch their blood sugar. And the goal of these patients is to keep their blood sugar between 140 and 180. We want to make sure that they're not too hyperglycemic and that they also don't become so hypoglycemic that we have even other additional complications. In patients who have had a TIA or a very mild stroke and someone with atherosclerosis of that carotid artery, a key thing that's done to help prevent another one or any stroke, if they've never had one before, is a carotid endarterectomy or a CEA. And the purpose of this is like what you see in the picture on your slide. So they make an incision into the carotid artery and then they can remove the plaque. This allows normal blood flow to be restored to the brain, therefore preventing a stroke again in the future. Carotid artery stenting can also be done in patients who are at risk for a stroke or at risk for another stroke. Now, when we think of a carotid endarterectomy and assessment of the patient post-op, a big thing we look at is those potential complications of that carotid endarterectomy. And that includes actually having a stroke. It also includes having some injuries to the cranial nerves. So the cranial nerves that we really assess very closely include 7, 10, 11, and 12. So go back and review those so you know kind of what we're assessing to make sure that those cranial nerves are still intact. Another thing that we potentially see is obviously infection, which we can see with any type of surgical procedure. You also have a risk for a hematoma to develop and then that to further cut off blood supply to the brain. So a big thing that we're monitoring post-op is if we see any patient who's starting to have a new onset of deficits, we can potentially expect them to have developed a clot in there that may necessitate the need for them to go back into the OR. Another thing that we look at with a CEA is I expect there to be swelling because of the surgery, but if it is severe enough, then I can actually have where it can potentially obstruct their airway. So I want to make sure that there's a trach available at the bedside just in case. After performing your assessment on a patient with an ischemic stroke with your focus and your priority being on their ABCs and then their neurostatus, then you can form nursing diagnoses based on what your patient's symptoms are. A big thing to assist in planning the patient's care is knowing their baseline prior to the stroke. So knowing the baseline gives them an idea of what the patient will be able to do with rehabilitation after a stroke. Nursing interventions for a patient with an ischemic stroke definitely includes helping the patient to improve their mobility and prevent some of the deformities that may occur with a stroke. So a big thing is proper positioning. So positioning is really important to helping prevent some of these contractures. So for example, with shoulder adduction, our goal is to prevent that adduction while the patient is in bed. So we position them with a pillow underneath that axilla to make sure that the shoulder doesn't become adducted and cause a contracture where they're not able to move it. On the next slide, you'll actually see a picture of the lady in bed. So it's the top left picture on the next slide that shows you how we can position them in bed to prevent that shoulder adduction. Another thing with the hands and the fingers, our goal is to position them so that they're barely flexed. So usually the palm should face upward, and this is going to be because that's the most functional position. So for the most part, our goal is positioning them functionally so that way they don't develop a contracture that is abnormal from the way they're normally supposed to be positioned. Another thing that's really important is an exercise program. So making sure they're doing range of motion. Hopefully, if they can do active range of motion, we want them doing that. And then if they're not able to, then we want to make sure we're doing regular passive range of motion. Another thing is position changes are really important. So we want to make sure we're relieving pressure on some of those pressure points to prevent the patient from developing skin breakdown. Another thing we want to make sure we're doing is, if they're sitting in a wheelchair or sitting in a chair, we want them to move around very frequently just so that they don't start putting pressure on certain areas that can then cause further issues. Now, when we look at good body alignment, our goal is basically for that patient to just maintain normal body alignment, so sitting up properly, and sometimes we have to use pillows and other devices to help us maintain that body alignment. Another thing our goal that we have is to help make sure that we're preventing some of those compressive neuropathies. So depending on how they're lying, we may actually see where they can put pressure on certain areas that then cause them to have these nerve pains. So we position them again in a normal anatomic position to help prevent some of those compression neuropathies. Another thing that we look at is preparing them for ambulation. So our goal is to get them up and ambulating as quickly as possible and use assistive devices as they're needed for the patient. Because many patients with a stroke become hemiplegic or have weakness on one side of the body, a big thing we have to look at is that arm and prevention of, further shoulder pain or shoulder injury. So we always want to make sure that we never pull or lift on the affected side. If we overstretch it or we pull it, we have a risk for dislocating it or partially dislocating it. So when they're positioned in a chair or at a table, as you see in the picture, we want to prop that arm up so that it's not just hanging. Another thing that can sometimes happen is the patient can kind of forget that side is there depending on which side their stroke is, and sometimes it can just hang, and because they can't really feel it, they don't know that they could potentially injure that. Another thing we can do to help prevent that shoulder pain is pharmacologic management. So things that can help decrease some of those neuropathies that can occur. So things like amitriptyline and gabapentin, those are sometimes used just to help with that pain that can occur after a stroke. Now, our ultimate goal is for the patient to be able to do as much as they possibly can for as long as they can. We want to help them develop realistic goals and have steps or things for them to do every day that will exercise them but not overdo it. So our goal is to work them out, but we don't want them to become overly fatigued or even discouraged if they're not able to do something. That's why realistic goals are so important. After a stroke, a swallow assessment has to be done within 24 hours. So many patients after a stroke do have issues with dysphagia or problems swallowing. So it puts them at risk for aspiration and then potentially pneumonia or sepsis. So within 24 hours, we want that swallow assessment done so we can determine what the patient is able to do. In some cases, patients may get that ability to swallow back with time. In some cases, they may not be able to. So based on what the swallow study shows, then we can teach them alternate methods for how to eat or alternate ways to swallow to help decrease that risk for aspiration. So some of these things can be to eat smaller bites of food, make sure that if their liquids need to be thickened or pureed, that we do that. And then if that doesn't work and the patient's not able to take anything by mouth, then we will, use enteral feedings. Another thing that's important is bladder and bowel control. So a lot of times patients lose that immediately after a stroke. So they may need some of that retraining to help them get that function back. In cases where they're not able to, they'll be doing intermittent catheterization just to make sure that the bladder is emptied and doesn't cause any further issues. Other nursing interventions for a patient with an ischemic stroke include helping the patient to cope with that diagnosis. So a big thing we want to make sure we're doing with our patients is kind of making sure they're oriented to reality. We want to give them confidence and hope, but we also want to make sure that it's realistic based on what they're going to be able to do after they recover. Another thing is communication. So with patients with a stroke, we want to make sure that we give adequate time and really allow the patient to speak. Another thing that we want to consider is when we're giving instructions or asking the patient questions, we want to make sure we're speaking slowly and listening very closely to the patient, giving them time to respond. Coping with sexual dysfunction, many times patients may need additional resources from other doctors and things to help them with that aspect. Some of the potential complications of an ischemic stroke that we've mentioned already is that increased intracranial pressure and even that risk for pneumonia if the patient's not able to clear their secretions. So our goal is basically just to monitor those two things very closely and step in if we do notice that they're developing one of those complications. The second type of stroke is a hemorrhagic stroke. Hemorrhagic strokes are caused by bleeding into the brain tissue. That bleeding causes increases in intracranial pressure, and this leads to a decrease in cerebral perfusion pressure, and this decrease in perfusion pressure leads to a secondary ischemia, meaning a lack of oxygen to the brain, leading to decreased brain function. So the most common cause for a hemorrhagic stroke is uncontrolled hypertension. The biggest thing to take away from a hemorrhagic stroke is uncontrolled hypertension. Management of patients with hypertension and making sure they're taking their medications appropriately is paramount to making sure someone does not have a hemorrhagic stroke. Some of the other causes include arteriovenous malformations, cancers, even some medications like anticoagulants. Another thing would be because of a subarachnoid hemorrhage from something like a ruptured aneurysm. And there's even some angiopathies that can cause intracerebral hemorrhage as well. But again, the most common cause for a hemorrhagic stroke is uncontrolled hypertension. So as you see in the picture on this slide, you can see what an intracerebral hemorrhage looks like. This would be a picture of what would occur if you had somebody with uncontrolled hypertension. This can also occur with patients who are on medications like anticoagulants or other illicit drugs, and the ultimate cause is because a blood vessel ruptures and then results in bleeding within the brain. An aneurysm is a dilation of the walls of an artery because the wall has weakened. So in that picture, you can actually see what a cerebral aneurysm looks like. These aneurysms can be related to things like atherosclerosis, hypertension, even having head trauma, or just with age, people can develop aneurysms. So rupture of one of these aneurysms is a potential cause for a hemorrhagic stroke. The picture on this slide shows you what an arteriovenous malformation looks like. So in that picture, the left side is what a normally artery, vein, and capillary should look like within the brain. The picture on the right is what an AVM looks like. So as you see, it's basically a tangle of these arteries and veins with no capillary bed. So it results in a lack of perfusion to that area, so it causes dilation of the arteries and the veins, and then potentially or eventually leading to a rupture of those because of all the pressure. So rupture of an AVM would cause a hemorrhagic stroke. A key differentiating sign of a hemorrhagic versus an ischemic stroke is a severe headache along with an early sudden change in the level of consciousness. Another thing that comes with that is nausea and vomiting and even potentially seizures. So in addition to those signs, you can also see some of those signs that are very similar to the ischemic stroke depending on where in the brain that bleeding was actually located. Now, if the hemorrhagic stroke has occurred because of an aneurysm or an arteriovenous malformation rupture, then again, you would definitely see that very sudden, severe headache and then a pretty sudden loss of consciousness. And in addition, you could, if they're still conscious, maybe see some visual disturbances and some of that pain or nuchal rigidity or that neck stiffness. If a patient comes in with potential stroke, they're going to immediately be sent for a CT scan. The point of the CT scan is to determine if it is a hemorrhagic stroke, which they will usually be able to see on that CT scan. If they have a normal CT scan and they still think that there could be some type of bleeding within the brain, they can do something like a lumbar puncture to help confirm that there is that subarachnoid hemorrhage. But again, going back to chapter 65 as well as chapter 66, we want to be careful doing a lumbar puncture in somebody who would possibly have increased intracranial pressure, because that can further increase the pressure. A cerebral angiography can also be done to show those vessels within the brain and see what they look like and if any of them have ruptured or if there is an aneurysm or an AVM. Now, our biggest thing is to help prevent a hemorrhagic stroke, and the top way to do that is to manage hypertension. By far, the best way to prevent a stroke is to control hypertension. And then in addition, helping to reduce many of the other risk factors that we talked about with an ischemic stroke. One of the big complications of a hemorrhagic stroke is obviously hypoxia to the brain, or lack of oxygen perfusion to the brain. So a big thing we look at when we're looking at patients who have had a hemorrhagic stroke and potential complications is to make sure that they have enough oxygen. Our goal is also to make sure that the blood pressure is within a normal range, meaning not too low and not too high. So we don't want it too high because we don't want the intracranial pressure to rise even more, but we don't want it too low because we don't want to further decrease how much oxygen is actually getting to the brain. Another thing we look at is watching the hemoglobin and hematocrit closely and giving IV fluids or potentially blood to help maintain volume. Another thing is a lot of patients who have a hemorrhagic stroke can also have seizures, and if they have a seizure close to when they have this stroke, we're also further reducing oxygen supply to the brain. So we want to make sure that they're on anti-epileptics at least while they are, in the acute phase, and then even potentially for several months to years after. Another big complication that's associated with a subarachnoid hemorrhage is a vasospasm. So a vasospasm, you'll actually see a picture on the next slide, is a narrowing of the blood vessel. So if a blood vessel all of a sudden spasms and narrows, it cuts off supply to that area of the brain. So a big thing we see is that most patients who have a vasospasm usually have it within about 7 to 10 days after their initial stroke. So the reason they find that they're at a higher risk is because at this point the clot is gone after the clot that developed after the hemorrhage. That clot has lysed, and now you have a higher risk of rebleeding because that clot is no longer there. And then what you usually see in these patients is a worsening headache along with a change in their level of consciousness. Another thing you may see is changes in their ability to speak or further weakness or paralysis of one side. So any new neurologic deficits can definitely indicate the potential that the patient has had a vasospasm. They have found that a lot of the vasospasms occur because of increased calcium into the cell. So a lot of times they try to use calcium channel blockers, and the big one they use is nimodipine to help decrease that risk for a vasospasm. Another thing is if the patient has an aneurysm, they've found that maybe early clipping of that aneurysm can also help prevent the risk for vasospasm. And then another thing that they've found is triple H therapy, which the purpose of triple H therapy is to expand the volume through fluids, so using fluid volume expanders to make them hypervolemic. Another thing they do is induced arterial hypertension. So if they increase that pressure within the vessel, it's going to be less likely to narrow. And then the last thing is through hemodilution, to dilute the volume within the blood vessel and basically make more water in comparison. And again, that kind of goes with the whole giving them extra fluid, keeping the pressure up, basically helps prevent that vessel from narrowing even further. But most research now is really showing that as long as the patient has normal volume and we're managing the same things that we were talking about with that cerebral hypoxia and adequate hemoglobin hematocrit, that usually is enough to help prevent those vasospasms in addition to using something like a calcium channel blocker. If there's bleeding in the brain, we can expect the pressure within the brain to rise. So a big thing we look at is that that brain is not as easily able to drain that CSF because there's so much extra blood taking up that space. So they usually will have something like a ventriculostomy that we can help remove some of that CSF fluid to help maintain a normal intracranial pressure. And we can also use an osmotic diuretic to help pull some of that fluid out of the cells and decrease that intracranial pressure. Another complication is hypertension. So patients may have had the stroke because of high blood pressure that was uncontrolled, but our goal of blood pressure management after this type of stroke is basically to lower the blood pressure, with our goal ultimately being about 140. Whenever we have a patient who has a systolic blood pressure greater than 220, we're going to use IV antihypertensives like labetalol or hydralazine or nicardipine to help bring that blood pressure back down to our goal of 140. And again, like I mentioned before, our goal is to bring it down to that goal, but not put them into hypotension where we would then further decrease the oxygen perfusion to the brain. Priority management for a patient with a hemorrhagic stroke is to give the brain time to rest and heal. So our goal is to allow the brain to rest, but also to prevent them from having rebleeding again. So most patients will be sedated on bed rest. Most of them will also receive anti-epileptics to prevent seizures, which would further reduce oxygen flow to the brain. And then because most patients will also be experiencing head and neck pain and even potentially fever, we're going to use things like Tylenol and cooling blankets to help manage those. Another thing is we're looking at surgical management to prevent further rebleeding. So if it's an aneurysm or an AVM, they'll do surgery to clip those or get rid of those. And then we're also looking at if it's anticoagulation that has led to the hemorrhagic stroke, we want to reverse the medication they were receiving. So we're thinking back to warfarin and warfarin and heparin, and our antidotes for those are what would be given for those two. And then we have our newer anticoagulants where we could use things like activated charcoal or dialysis to help reverse the effects of those anticoagulants and prevent further rebleeding. Another thing we're looking at is blood sugar. So we are going to monitor that blood sugar very closely to make sure that it doesn't drop too low and that it doesn't go too high, because either extreme is associated with a poorer outcome. Another thing, because we're trying to prevent rebleeding, we could potentially put them into the other end where we have a higher risk for blood clots. So we want to make sure that we are using SCDs and even using something like low molecular weight heparin or unfractionated heparin to prevent those DVTs. If a patient requires surgical management of a hemorrhagic stroke, our signs that indicate they need to be surgically evaluated is if their neuroexam is continuing to worsen or their intracranial pressure is rising so much that they're having compression of their brainstem, they would immediately go into surgery to try to save the patient's life. But if the patient has an intracranial aneurysm, our goal is to perform surgery once the patient is considered stable. And the purpose of doing that is to either clip or cut the aneurysm or reinforce it to make sure that it doesn't rupture again. So on the next slide, you'll actually see a picture of some of these different surgical management techniques that can be used. We can also do endovascular therapy, which is going in and putting in a coil or embolizing that vessel or occluding the aneurysm. We can even put in stents that will help divert blood flow away from that aneurysm to prevent it from rupturing. Complications of any of these different types of surgeries are things like rupture of that artery, occluding that artery and causing further lack of oxygen supply to the brain, and even the risk for things like GI bleeding, fluid and electrolyte disturbances, and some psychological symptoms like being disoriented, delirious, psychosis, hallucinations. All of those different things can also occur after a surgical management of an aneurysm. Priority management for a patient with a hemorrhagic stroke focuses on A, B, C, D. So airway and breathing come first, then circulation, and then our close neuro monitoring. Now, if a patient has an aneurysm, we're going to put them on something called aneurysm precautions, and this is very similar to what we see with somebody with an increase in intracranial pressure. So we're going to prevent those increases in intracranial pressure, which can cause an aneurysm to rupture. And we're also going to keep their environment very non-stimulating. Keep them on bed rest, limit visitors, and make sure that they're as low stress as they can possibly be. As we've mentioned before, it is important to keep a patient who's had a hemorrhagic stroke very calm and on bed rest to help minimize that stimulation that can further exacerbate their symptoms. But an important thing is to keep the patient informed and talk to them as we are performing different interventions. Keeping them informed is going to help minimize some of the anxiety that can occur being in a critical care type environment. Now, in regards to complications, we've already talked about the vasospasm and our management of that. If a patient does develop seizures, we talked about that in a previous chapter as well, and our focus is on airway and breathing, and of course safety for our patient. And again, most of these patients will be on anti-epileptics to prevent any or future seizures. Another potential complication for a patient who's had a hemorrhagic stroke is hydrocephalus. So the bleeding within the brain impairs how well the cerebrospinal fluid is able to circulate, so it builds up and causes an increase in fluid in the brain. This can occur within 24 hours to potentially weeks after the initial stroke. So if the patient has a sudden onset of being difficult to arouse or going into a coma, that can indicate possible hydrocephalus. So most of these patients are going to be managed by the insertion of a ventriculostomy, and then we'll be able to drain that CSF, which will gradually improve those symptoms. Another thing that we talked about before is that risk for rebleeding. So that's why we make sure that that blood pressure is at our goal of around 140 systolic. And then also this is why we secure that aneurysm as quickly as possible to prevent it from rebleeding. Another potential risk factor with a hemorrhagic stroke is hyponatremia. So a lot of these patients develop something called SIADH, or cerebral salt wasting syndrome, and this is where my kidneys basically are unable to hold on to that sodium, and it results in a pretty severe hyponatremia. So management of patients who develop this hyponatremia is IV hypertonic saline.